Health to Study Session 4. Hepatitis B. Introduction. Hepatitis B infection is an infectious and contagious disease. In cases such as viral inflammation of the liver, nurses and health workers are particularly at risk. HBV being isolated in blood, saliva, semen, vaginal secretion can be transmitted through mucous membrane and break in skin. The liver lies on the right side of the abdominal cavity, beneath the diaphragm. Blood is carried to the liver via two large vessels called the hepatic artery and the portal vein. The hepatic artery carries oxygen-rich blood from the aorta. The portal vein carries blood containing digested food from the small intestine. Pathophysiology, liver function, metabolic functions, THO metabolism, glycogenesis, conversion of glucose to glycogen, glycogenolysis, breaking glycogen to glucose, gluconeogenesis, formation of glucose from amino acid. B. Protein metabolism, synthesis of non-essential amino acids, plasma protein, development of clotting factors, urea formation from ammonia. C. Inactivation of drugs and harmful substances and secretion of the product. Steroid metabolism, conjugation and excretion of gonadal and adrenal corticosteroid hormones. D. Fat metabolism, synthesis of lipoproteins, breakdown of triglycerides into fatty acids and glycerol, formation of ketone bodies, synthesis of fatty acids from amino acids and glucose, synthesis and breakdown of cholesterol. E. Metabolism and elimination of bilirubin, storage functions of the liver, glucose, glycogen, vitamins, fat soluble, ADEK, water solution, B1, B2, cobalamin, folic acid, fatty acids, minerals, iron, copper, amino acids, albumin, beta-globulins. HBV leads to inflammation of the liver cells and disruption in vital functions. Inability of the metabolized bile leads to accumulation of unconjugated bilirubin. Appearance of bile pigment in urine, dark-colored urine, nausea and vomiting due to inefficient bile delivery to the intestine for emulsification of fat or poor digestion, irritation of the GTI. Manifestations: anorexia, nausea and vomiting, headache, splenomegaly, weight loss, pruritus, clay-colored stool, dark urine, fatigue, fever. Hepatitis B. Diagnostic procedure, detailed patient story, history, hematologic analysis for HBV, liver function test, serum bilirubin estimation, prothrombin time. Management goals: A. Rest the liver. B. Maintain nutritional intake. C. Provides adequate information about the disease. Functional health patterns, health perception, health management pattern, history of disease, possible exposure to HBV, ingestion of hepatotoxic agents, high risk of sexual behavior, nutritional metabolic patterns, weight loss, nausea and vomiting, feeling of fullness in the right upper quadrant, elimination pattern, dark urine, light colored stool, constipation or diarrhea. Nursing diagnosis: altered thermoregulation related to infection and inflammatory process, altered nutrition-less body requirements related to nausea and vomiting, self-care deficit altered family process related to disease and hospitalization, cognitive perceptual pattern, right upper quadrant pain, liver tenderness, headache, pruritus, activity exercise pattern, fatigue, arthralgia, myalgia. NOC: adequate rest, good nutrition, prevention of transmission, relief of symptoms, health education. Evaluation: evaluate effectiveness of nursing care, freedom of household members of the infections. Clients can verbalize appropriate measure to prevent infection, adequate rest, weight remains stable. Prevention of viral hepatitis, general measures, hand washing, proper personal hygiene, environmental sanitation, control and screening of food handlers, serologic screening while carrying virus active immunization. HAV to everyone over 2 years. Use immune globulin post-exposure prophylaxis, early administration, 1 to 2 weeks post-exposure to those exposed. Prophylaxis for travelers to areas of HAV is common if not vaccinated with HAV vaccine. HBV and HCV, percutaneous transmission, screening of donated blood, use of disposable needles and syringes, sexual transmission, acute exposure. HBIG administration to sexual partner of HBV/AG positive person. Administer HB vaccine to uninfected sexual partners. Use condom for sexual intercourse. General measures: hand washing, avoid sharing toothbrushes, blades, and administer HBIG for one-time exposure. Needle stick, contact of mucous membrane with infected material, active immunization with HB vaccine. HBV immunization, standard course, 3 injections over 6 months, 1 month and 6 months respectively. An accelerated course over 2 months is possible for combined hepatitis A and B vaccines. Booster dose at 1 year is recommended. Adults who need protection very quickly can have a schedule over 21 days administered intramuscularly into deltoid muscle. A course may give lifelong immunization. Health professionals: 1 further booster at 5 years is recommended. Antibody titers should be tested in health professionals 2 to 4 months after the primary course. Note: a titer above 100 IU/mm is regarded as adequate. Poor responders 10 to 100 IU should have a booster. Titer below 10 should repeat the course. Smokers, obese, and those above 40 years are more likely to fail to respond. Alcoholics have lower seroconversion rates, particularly those with advanced liver diseases. Patients who are immunosuppressed or renal dialysis may also respond less well and require larger or more doses of vaccine. Failure to produce any antibody after 2 complete courses should not be seen as necessary meaning to immunity, as immunity to the disease is largely cell-mediated rather than by antibody. Who needs it? Non-occupational exposure to blood or body fluids, sexual or needle sharing contact of an HB SAG positive person, victim of sexual assault. End of study session 4. Thanks for listening.